Good afternoon, Dr. Shu.
Good afternoon.
If we wanted to educate this jury about your treatment of Christopher Kidwell, is that something that you could help us with?
Yes.
Thank you. Are you a neurosurgeon?
Yes.
Are you also a plant mom?
Yes.
Your plants look rather healthy. I just wanted to comment on that.
Thank you.
What do neurosurgeons do?
Neurosurgeons take care of the brain and spine for any anatomical issues that require surgery.
Thank you. Do you have an area of focus within neurosurgery?
I currently do primarily skull base and tumor surgeries, but I was previously a general neurosurgeon who did 50% spine work as well.
Okay. Where did you attend medical school?
I went to the University of Maryland.
And after medical school, what did you do?
I did my neurosurgical training at Stanford University. And then after that, I took my first job at Allegheny General Hospital in Pittsburgh. And then I came to Kaiser, Northern California in 2020.
Thank you. And are you board certified?
I am.
And what are you board certified in?
In neurosurgery.
Where do you currently practice?
I practice at Kaiser Redwood City.
What type of patients do you typically see in your office practice?
I see all kinds of neurosurgical patients, so that will range from brain to spine, although my current concentration is primarily in brain tumors.
Do I understand correctly that at one time you performed spine surgeries, but you no longer perform spine surgeries at Kaiser?
I still do spine surgery, especially as needed on call, but that's not my subspecialty practice.
Okay, thank you. What is the goal of spine surgery?
The goal of spine surgery is to maintain the safety of the spinal cord and the nerves.
And what is a microdiscectomy?
Microdiscectomy is a surgery where we make a small opening in the bone of the spine so that we can see an individual nerve as it passes by the disc space. And then we try to remove bone, ligament, and disc that may be compressing that nerve.
And what is a laminectomy?
A laminectomy would be a procedure where we just remove the bone that's posterior to the nerves in the spinal cord.
Okay. Are laminectomies and discectomies sometimes used interchangeably?
Yeah, they are all done with a posterior incision and can decompress the nerves of the spine. But again, the laminectomy is typically just bone work, whereas a discectomy will also include some removal of the soft tissue of the disc.
When is spine surgery considered an emergency surgery? Something that's not elective?
Yeah, emergency surgery would be indicated if there's a rapid onset of neurological deficits. So rapid onset of weakness, numbness, or loss of bowel and bladder control would be considered an emergency.
Within your practice, do you talk to people who are considering spine surgeries?
Yes, I do.
Okay, and is that a serious decision for your patients that have been recommended for a spine surgery?
I think for every patient who is considering surgery, I hope that they are taking that discussion seriously.
In your experience, is that decision often made with input from family members?
Yeah, oftentimes patients will come actually to the appointment with a family member or have them involved.
Let's talk about this particular case. Have you had the opportunity to review your notes regarding Christopher Kidwell?
I have the note that was included in Exhibit A.
Wonderful. When did you first evaluate Christopher Kidwell?
This note, I believe, was dated February 4th, 2022.
Do you have an understanding of who referred Mr. Kidwell to you?
I see that the referring physician is Dr. Treenan, who I believe is a PMR physician.
Okay. PMR, would that indicate pain management?
It's physical medicine and rehab. So they often see our patients who have spine and nerve problems.
Thank you. When you had your appointment with Mr. Kidwell, did he give you a history of his current symptoms?
Yes, he did.
What were his current symptoms when you evaluated him?
Per the note that's documented, it sounds like what he reported was several years of problems with his back and leg that had gotten worse over the course of the preceding 6 months. And it sounded at that time that he was having pain that was shooting from the back down into the leg on the right side. That was worse with certain activities. And he also had some numbness associated with that, and that he had already tried a number of conservative measures for management, including injections and therapy.
And do you have an indication of how many epidural injections he had before he saw you?
In my note, it documents that he had 4 previous injections.
Did Mr. Kidwell give you a history of being involved in a motor vehicle collision?
He did report that he had a motor vehicle collision in October of 2019, and he thought that his symptoms had been present since that time.
Did Christopher give you a history of taking narcotic pain medicine to control his symptoms?
He reported taking Flexeril and Norco. Norco is an opiate.
In your evaluation of Mr. Kidwell, did you find evidence of sacroiliac joint dysfunction?
We did a video visit, so it wasn't possible for me to assess that through the video visit.
Okay. Have you seen any evidence that Mr. Kidwell is suffering from SI joint dysfunction?
Not with what he was reporting to me, because the nature of the pain extending down into the leg, that's more consistent with radiculopathy or nerve irritation.
And did he give you a history of having 20% improvement following an epidural injection at L5S1?
With at least the last injection, yes, he reported a 20% improvement.
Does that indicate that the S1 nerve is one of the sources of Mr. Kidwell's pain?
It increases the likeliness that his pain is associated with the disc if the injection did help.
In your practice, do you generally believe what a patient is telling you originally caused the pain and symptoms?
Yes, I only have that data, and so I don't have any other data to suggest otherwise.
Did you review Mr. Kidwell's lumbar MRI?
I did.
Was there evidence of an annular tear in the L5S1 disc?
Yes, his MRI suggested a right-sided tear at L5S1.
Was there evidence of nerve compression on Mr. Kidwell's MRI?
Yes, on the imaging, it did show that it was narrower on the right side at L5S1 compared to the left.
And which nerve would be impacted by that compression?
Yes, it can be the L5, but more likely the S1 nerve would be impacted by that.
Does Mr. Kidwell have a partially lumbarized S1 vertebra?
I actually can't tell because of the quality of this image that's in Exhibit A.
It's a printout and it's all black, and it's not a, you can't read that MRI that's on the printout. Is that true?
Yes, I'd have to go back to his original imaging, but I can't tell from Exhibit A.
Thank you. Is nerve compression something that can be addressed with spine surgery?
Yes.
Is Mr. Kidwell's nerve compression on the right side of L5S1?
Yes.
Does Christopher's disc herniation at L5S1 correlate with his distribution of pain?
Yes.
Is Mr. Kidwell currently a candidate for surgery to treat the right foraminal stenosis at L5S1 with a microdiscectomy of that segment?
At the time I talked to him in 2022, I did offer him surgery for that, but I have not seen him since that time.
Okay. And we already talked about how microdiscectomies and laminectomies are very similar, but in a laminectomy, only bone is taken out. Is that correct?
Correct.
Assuming that Mr. Kidwell has a microdiscectomy, during that procedure, what material would have to be taken out to relieve pressure on the S1 nerve root?
A small portion of the bone that would be on top of the nerve would be removed, and then the ligament above it. And then the microdiscectomy portion is reaching around the nerve and removing the disc fragment that's compressing the nerve in front of it.
Would the right-sided L5S1 microdiscectomy you proposed help with the right-sided leg pain he was experiencing when you evaluated him?
That's what the goal of the surgery would be, yes.
And would the goal of the discectomy be to essentially create more room for the S1 nerve to avoid compression?
Correct.
So if I understand correctly, the goal of the discectomy would be to create more room for the S1 nerve. My question to you is, would a fusion at the level of L5S1 also decompress the S1 nerve?
It certainly decompresses the nerve as well, but it's a much larger surgery with a longer recovery time. And in addition to decompressing the nerve, it also helps with instability if that's a problem at that level. But at this point, I didn't suspect that he had instability, so I didn't offer him the much larger procedure.
And a fusion would avoid instability, true?
Yes, it corrects instability at a given level by fusing the joints together so it can no longer move at that level of his back.
But fusions create mobility issues. Is that the case?
You're going to lose about 10% of motion every time you fuse one level of the back. And also it puts additional strain to the joints above and below to compensate for that loss of motion. So especially in a younger man, I would generally tend to avoid fusion if possible.
Assuming Mr. Kidwell got a fusion at L5S1, within roughly 20 years of that fusion, what would happen to the L4-5 disc?
Over time, there's more and more strain at the L4-5 disc. And so generally that's going to be the next disc that we run into degenerative issues. So more problems with the joints and with the disc there.
And during that process of degeneration, will that disc become a source of pain and discomfort?
So potentially it could. That's called adjacent level disease. So that's a well-known phenomenon. So it could, but no guarantees either way.
Now, to a reasonable degree of medical probability, is the microdiscectomy you proposed reasonably necessary to alleviate Mr. Kidwell's leg pain and to lead to a better quality of life?
Yeah, this type of surgery is for primarily quality of life. So in terms of necessity, that's why I left it up to Mr. Kidwell himself, whether he wanted to have surgery or not, because ultimately it's about his own pain management and symptoms, but it's not life-threatening.
Thank you. Did you discuss the risk associated with the proposed right-sided L5S1 discectomy with Mr. Kidwell?
We did discuss the surgery, which I believe included the risks and benefits, and I included the risks and benefits of surgery in a message to him on his KP app. Thank you.
And what are the primary risks associated with a discectomy at that level, L5S1?
So the risks include the fact that he could have continued pain down the leg or worsening pain, injury to the nerve itself, which could cause worsening weakness, numbness. The disc could re-herniate in this area when we take some of the disc out, and possibly he would need a repeat surgery for that. And as with any surgery, infection, anesthetic risk, blood loss. In addition, anytime we work around the nerves, there's a risk for spinal fluid leak, which could lead to additional surgical procedures. And then down the line, in the future, he could be at risk for instability and needing a fusion later on.
And that was going to be my next question. If my understanding is that the herniation is to the right side of Mr. Kidwell's lumbar spine.
That's correct.
And would part of the facet joint need to be taken away to decompress the S1 nerve?
In a microdiscectomy, we take up to a third of the facet joint.
And taking away that part of the joint, is there a risk that that would lead to instability of the spine?
That's correct.
So that's why one of the risks to this microdiscectomy would be instability leading to a more serious surgery, being the spinal fusion?
That's correct. Anytime you remove bone and ligament of the joint, you could cause some worsening stability in that area. And even if not immediate, later down the line, they may need a fusion.
Now, assume that Mr. Kidwell gets a microdiscectomy and a third or more of his right facet joint at L5S1 is taken out to decompress the nerve, and it leads to instability. More likely than not, would that instability need to be treated with a later spinal fusion?
If he became unstable at that level, yes, he would be a candidate for a fusion.
Are you aware that Christopher told his doctors he was not ready to pursue a discectomy at this time?
He told me that he didn't want to schedule a surgery at that time, and I just told him to contact me if he wanted to proceed with surgery.
Have you had patients that have put off spine surgery until the pain's unbearable?
Yes.
In your experience, do some patients continue conservative treatment in the form of injections and other therapies even after a spine surgery has been recommended?
Yes.
And in your experience, do some patients pursue spine surgery when it's been offered?
Yes.
And is it fair to say that that is a risk-benefit analysis that a patient makes?
Yes.
Thank you, Dr. Xu. I have no further questions at this time.
Your first and only visit with him was conducted through video conferencing, correct?
That's correct.
And you had no chance to examine him, is that correct?
That's correct.
Okay. When he told you that he was in a car accident and he thought that's what it started in October of 2009, did he tell you about any other previous treatments he'd had for lumbar radiculopathy prior to October of 2019?
No, we didn't discuss any symptoms prior to October of 2019 or any treatments.
Did he discuss any previous chiropractic treatment he'd had with you or had with anybody?
No, we didn't discuss any chiropractic treatment.
Okay. Then in preparing for your video consult with Mr. Kidwell, I see that you reviewed the MRI, correct?
Correct.
Did you review any of the other Kaiser treating doctor's notes prior to that meeting?
I would have to speculate that I likely read Dr. Treenan's notes, but I don't have any documentation of that, so I can't say for certain.
Okay. Is that something you usually document in your notes, or is that something that you just usually do?
That's something I usually do to get prepared for an appointment.
Okay. You have access to the Kaiser record database for Mr. Kidwell if you wanted to look through his past treatment prior to your video conference?
That's correct.
Okay. And your thoughts are that you probably may have looked at Dr. Treenan's, correct?
Most likely I look at the referring physician's notes so I know why the patient is coming to me.
Okay, but you wouldn't look at all the notes from his primary care physicians, emergency room visits, and things of that nature.
No.
Would that be fair? Okay.
Yeah, correct.
Okay. Are you familiar with the Dr. Yu-Jung Kim, spinal surgeon?
No.
Okay. Are you aware of a spinal surgeon by the name of Rashad Ashtori?
No.
Okay. Haven't reviewed any reports or records from either of those two prior to this deposition?
No.
Did you review any records or reports from a Dr. Kenneth Light prior to this deposition?
No.
Did you ever speak with a life care planner about Mr. Kidwell and his future potential medical treatment options?
No.
Okay. You don't intend to offer any opinions about what caused his lower back lumbar radiculopathy, do you?
I wouldn't know anything about the etiology of how this began other than what the patient told me by time was directly preceding his symptoms.
Okay. During your consult with Mr. Kidwell, did you find any instability in the L5S1 joint?
No, it didn't sound like either by his symptoms or by his imaging that there was instability at L5S1.
And you have not had any examinations or treatments of Mr. Kidwell since your one video conference on February 4th of 2022, correct?
I don't believe so.
The surgery that was offered, you wouldn't consider that an emergency surgery, correct?
No, it was not an emergency surgery.
How many MRIs did you have access to at the time of your examination? Is it just one?
It looks like the MRI that I reviewed and I pasted into the note was only from one exam.
Okay. If there is no instability in the L5S1 joint, is a fusion surgery something you would recommend in a patient?
I personally would not.
And why is that?
I'm a more conservative surgeon, so I prefer to offer the smallest surgery necessary to fix the problem that the patient currently has, rather than to start with a larger surgery.
Discectomy, it would, I think I saw something in your notes. Is it fair to say that the pain that was shooting down the right leg, but not necessarily the lower back pain?
The goal of a discectomy is to decompress the nerve, which can only treat pain going down into the leg. Back pain itself is much more complicated and related to usually not just a disc, but many of the joints in the back. And so that's not typically a surgical problem that we can guarantee pain relief for.
Okay. So would it be fair to say that the discectomy was meant only to relieve the pain shooting down the right leg?
Correct.